Are on video. Take a quick moment to introduce Dr. Ed Cladera and Pam Gould, our presenters from AristaMD. We're so glad to have you as longstanding supporters of the eConsult work group and always offering great examples of what you're seeing out there in eConsult use. Some great cases that we're going to hear from Dr. Cladera and Pam today. Dr. Cladera is a hospitalist in San Diego. We were just talking about the fact that we started out in California, and we're glad to see folks from across the country on today. And Pam happens to be in Massachusetts today, so thanks for joining us, Pam, on East Coast time. Pam is a nurse, so we're so glad to have you as clinicians share your, your experience and case examples in the use of eConsult. So with that, Dr. Cladera and Pam, I'll let you describe a little bit more about your background. I'm going to hand off to you, and thanks for kicking us off with your examples of eConsult in addressing patients' needs. Go ahead.
Thanks so much, Libby. So we'll move to the next slide. I am the Chief Growth Officer here at AristaMD, so really feel privileged to be able to have this time today to speak with all of you. Dr. Cladera is our medical director. He will be co-presenting with me as we take you through some of the interesting cases we've seen utilized for e-consultation. A lot of this is occurring, it has occurred pre-pandemic, but we have seen a lot of really interesting use cases post-pandemic. So we're going to talk through a case today. I do want to say just up front that all of the information we're sharing has been completely de-identified, and it is exemplifying what an e-consult looks like, or some of the e-consults that we've seen in real life for a patient with complex conditions. So although it's not an actual patient, it is representative and illustrative of what we're seeing. As many of you know on the call and are familiar with e-consultation, specialty care access, it shouldn't be difficult. It should be something that we can readily access when we need it. But we know not only what we saw during the pandemic, but post-pandemic, we're seeing that specialty wait times have across the US more than doubled. And in many states, this has quadrupled or tripled as far as tripled and quadrupled as far as wait times for people waiting to get into specialty care. We also know that there are certain populations where this wait time has even exacerbated more. E-consults can certainly help this, but when we look at other populations, if we go to the next slide, you can see that when we have folks who have inequities in care, people who may have reside in rural areas, may not speak English as a primary language, may have lower income status, or are minority, accessing specialty care can even be more difficult in some regions. So when we think about healthcare disparity and we think about access times being prolonged, we know that e-consults can change this dynamic. So just a quick refresher on what is an e-consult. There are various ways that e-consults can be performed, but in its simplest form, it is enabling a primary care provider to obtain specialist advice for a patient's care treatment plan through a specialist. And this can be done, usually it's done through an asynchronous telehealth methodology. Sometimes there are some platforms where these do occur face-to-face, but more often than not, it is asynchronous, meaning that it is done in a way that does not disrupt a workflow for a primary care physician. They're able to put in supporting information, oftentimes clinical information, that can then be reviewed by a specialist in the appropriate condition relating to what's going on with that patient. They will then weigh in on what they think are the best treatment recommendations based on evidence-based medicine, and that can then be deployed for the primary care to then direct care for the patient. So some differentiators that we see is that we look at consultation in a couple of different ways. We know consultation is a request by a qualified provider for the advice of an opinion of another, usually a specialist physician. Many times this may take place through a face-to-face referral. So this is where there's actually a transfer of care from the physician, the primary care, to the secondary physician, who will then maintain the care for that need. With e-consultation, again, we're doing this all electronically, so you're getting that really quality advice back from the specialist, and it's precluding a transfer of care. So we're keeping the care under the trusted purview of the primary care provider. There's a number of reasons why that works. We keep care in an area where many times, especially when we talk about healthcare disparities, it isn't uncommon for a patient to seek out a primary care physician who is meeting certain criteria that's important to them. If they speak English as a second language, it's very common that the primary care provider will speak their native language. If they have certain religious mores or values, they will often seek out a primary care provider that fits into those mores and values. And whatever the rationale may be, when we take a patient away from that very trusted care environment, in some ways we start to fragment and break the care. So e-consultation really does support the primary care provider as the quarterback for the patient's care and keeping care less fragmented. So how e-consults are different, as we mentioned before, you're requesting advice to get care guidance on care plans for patients that you're treating. Typically, we see that e-consultation is appropriate for anything that we would consider lower acuity specialty care needs, things that are not urgent, emergent, or procedural. You will receive recommendations from a specialist panel. These can consist of panelists who have years of experience. They may be board certified. In the case of AristaMD, they're all US based. These are folks that are weighing in on the care and being able to guide the physician as to whether or not the patient A, needs to be seen by a specialist, and B, if it is lower acuity, what are the best course, or what is the best course of treatment for managing this patient. In many instances, we're sharing clinical information. That's important. By giving a clear clinical picture of what's going on with the patient, the specialist who's weighing in on the care can provide the best evidence-based response. And again, no video is required, although there are some offerings out there that do enable that if it is desired. So we're going to go through, as I mentioned, I wanted to give you a sense on the call of how e-consultation can be an extremely viable option for a complex patient. Someone who has multiple comorbidities, multiple things going on, and at the same time needing specialist advice. So we're going to talk about Penny. And as I mentioned, Penny is illustrative of the types of e-consults that we're seeing coming through now for patients that have chronic or complex cases. In this case, Penny is a 55-year-old female who was diagnosed with insulin-dependent diabetes at age 12. Penny utilizes an insulin pump, and she has done so since she was 42 years old. And she does perform blood glucose monitoring through a continuous glucose monitor, or CGM. Penny also suffers from depression, and she's treated for depression through a daily dose of Zoloft, 50 milligrams. Penny was recently diagnosed with atrial fibrillation and prescribed atenolol, 25 milligrams twice daily. So we've got a number of things going on with Penny. What's happening that's causing Penny to present to her physician is she has increased symptoms of lethargy and depression. She notes that she's feeling more blue than usual. She's sad, she's unmotivated. And recently she's been struggling to keep her blood glucose under 140, which is usually not problematic for her. But she's had no change in diet and exercise, so this is concerning. So Penny decides to schedule appointments with her cardiologist, her endocrinologist, and her psychiatrist. Here's what Penny finds out. The available appointments for her to get into these various specialists are pretty stretched out. Her cardiology appointment, the soonest she can get seen is in 6 weeks. Her endocrinology appointment, the soonest that they can see her is 9 weeks. And her psychiatrist has told her that they can get her in 7 weeks. Really discouraged, Penny calls her primary care provider because she just feels like I'm not going to be able to wait 6 weeks to feel better. She's worried that she may need to go to the emergency room if these things cannot be resolved. The blood sugars, the feelings of sadness, they're overwhelming. So Penny calls her primary care physician for the needed assistance. Ed?
Thank you, Pam, for that fantastic introduction and getting us on the right slide here. Penny is trying to avoid trips to the emergency department, and her primary care provider is able to reach out to AristaMD to our platform and reach out to a couple of specialists to make sure that we handle this patient's condition appropriately. Most recently, due to Penny's diagnosis of atrial fibrillation, atenolol has been prescribed, which potentially could be causing Penny's feelings of depression. The PCP reaches out to psychiatry for an e-consult to see if she can get further direction on lethargy and depression. Next slide. The primary care provider reaches out to psychiatry. Up at the summary at the top of the slide on the right side, the psychiatrist is able to provide the primary care provider initial recommendation that treatment options are available at the primary care level. The psychiatrist is able to reiterate the importance of addressing the patient's escalating depression on Zoloft, 50 milligrams daily. Zoloft's generic name is also called sertraline. It is an antidepressant. The maximum dose of Zoloft is 250 milligrams. I always like it when the specialist provides primary care providers with clinical pearls to include pharmacologic information for patient safety. The recent addition of atenolol could potentially be worsening the Penny's lethargy and depression. It is unclear, however, if this is an interaction with the patient's Zoloft medication. Both drugs, however, have not been demonstrated to have negative interactions. Penny also has dependence on insulin. She's insulin dependent and uses a insulin pump. Her glucose has been associated to be worsening with the addition of atenolol and may also be the source of lethargy and depression having the addition of atenolol. Thus, the psychiatrist is able to make the recommendation for the primary care provider to also reach out to cardiology and endocrinology, not only to address the medications needed for atrial fibrillation in the presence of insulin-dependent diabetes, but also how the combination of medications could impact the patient's suboptimal glucose control. Of interest, studies have been confirmed a link between depression and atrial fibrillation. However, causality has not been established. We don't know which one comes first, depression or AFib in this combination. So it's wise that the primary care provider wants to address both issues, both comorbidities. The psychiatrist recommends the initial step would be to pursue the correct medication for Penny's atrial fibrillation. Also, glucose monitoring. She does need to be continued to be managed during this care. And also, the psychiatrist would not titrate Penny's Zoloft until AFib and also the diabetes are managed appropriately. Once this is achieved, if depressive symptoms continue, the psychiatrist recommends titrating Zoloft by 25 milligrams increments at a 7-day interval if Penny tolerates it. Maintain each new dose for at least 4 weeks before considering the next increase of dosing. And I always appreciate it when the specialist is able to provide the pharmacologic input to make sure that the medications are being titrated safely for Penny. Next slide. Thank you. So after reaching out and obtaining information from psychiatry, the primary care provider is able to reach out to cardiology. From our perspective, the cardiologist on our platform is also able to review other subspecialist information. In this particular case, psychiatry. The PCP wants to request additional information and guidance for atenolol for the diabetic patient with a history of depression. The primary care provider reaches out to the cardiologist. The cardiologist's initial summary is treatment options are available at the primary care level. This is a most interesting case, one that has atrial fibrillation, insulin-dependent diabetes, and also depression. The cardiologist is able to review what other subspecialists recommended and also recommends not only reaching out to psychiatry, but endocrinology for an overarching approach to Penny's multiple comorbidities. Understanding that medications also play a role, and specifically interactions in between medications for this patient with multiple comorbidities. There are several medications to choose for managing atrial fibrillation. The cardiologist notes that currently the patient is on atenolol, which has been shown to increase blood sugars, whereas Coreg, also known in generic form as carvedilol, also a beta blocker like atenolol, however, it has alpha-1 blockade properties as well, does not increase blood sugar. In comparative studies, medication to manage AFib with Coreg improved while atenolol worsened insulin-resistant and non-diabetic hypertensive patients. Since Penny is a type 1 diabetic, insulin resistance is less of an issue. She has an insulin pump. But however, to remove concerns, atenolol's impact on Penny's blood glucose, the recommendation would be to change your medications to Coreg 3.125 milligrams twice a day for 2 weeks. If the patient tolerates the initial dose, to increase further to 6.25, subsequently to 12.5, or even as high as 25 milligrams twice a day over successive intervals of at least 2 weeks. We want to make sure that the patient is able to tolerate these doses, and for the administration of a lower dose, preferably to control the patient's blood pressure and heart rate goals, that they're achieved, or higher doses if they are not tolerated. So I always appreciate it when a specialist provides directions on the titration of medications for patient safety. Next slide. So what does a PCP have so far? They have the recommendations from a psychiatrist initially, the cardiologist, and third but not least, we have endocrine input from the endocrinologist to assure we have an optimal treatment plan for a patient with multiple comorbidities, who's being switched from atenolol to Coreg per guidance of a cardiologist. But we also want recommendations and treatment plan with an endocrine perspective, specifically from the endocrinologist. Next slide. The endocrinologist is able to review information not only from the psychiatrist, but also the cardiologist. On our platform, a specialist has the opportunity to review prior e-consult responses across the subspecialty. The summary for this recommendation is treatment options are available at the primary care level. For this insulin-dependent diabetic patient who uses an insulin pump with recently prescribed atenolol, the endocrinologist is able to mention that, yes, this could be interacting with the patient's insulin and causing patient's symptoms, and also, unfortunately, uncontrolled glucose levels. Beta blockers effectively treat high blood pressure, but may raise blood sugars. In recent studies, atenolol has been associated with approximately 20% reduction in insulin sensitivity, meaning that it requires more insulin to get the job done. Further, atenolol has been associated with side effects, including depression and fatigue as well. Coreg, also known as carvedilol, is proven effective in managing atrial fibrillation without the side effects of raising blood glucose levels. It is noted co-administration with Zoloft has been shown to reduce the concentration, specifically the plasma concentrations of Coreg. This is important to know. As Zoloft is being increased, the effects of Coreg with reduction of plasma concentrations could be decreased. Care should be taken when dosing Zoloft to appropriately achieve the atrial fibrillation management objective while using Coreg. The endocrinologist makes a final recommendation. Please confirm with the psychiatrist if Zoloft should be continued on this patient, who will now be using Coreg to replace the patient's atenolol. Next slide. And reviewing the recommendations of the treatment, the primary care provider was able to obtain recommendations from 3 specialists. The primary care provider is able to make the changes for Penny from atenolol to Coreg. The primary care provider is able to follow up with psychiatry to confirm that, yes, we do want to continue Zoloft for Penny with reassessments of patient's symptoms in 2 weeks. And a clinical pearl is we always want to make sure that our patients with depression, we rule out that they are not having suicidal ideation and no intent to harm. The primary care provider utilizes specialist guidance to manage Penny's complex multiple comorbidity care needs. And at the same time, the primary care provider is able to stay at the center point of this care delivery. Next slide. Overall, and the encompassing plan is we're going to switch one beta blocker, atenolol, for another beta blocker with alpha-1 blockade properties, Coreg 3.125 milligrams twice a day for 2 weeks. We're going to titrate, and if the patient tolerates it, we can increase Coreg to 6.25 milligrams for 2 weeks. Patient safety is an utmost. We want to make sure that we repeat an EKG as the patient is on a beta blocker. And we want to also check the patient's glucose levels. This patient in particularly has a continuous glucose monitoring system, and if it can be updated to the records, Penny can forego glucose checks at a laboratory setting. We're going to continue to control atrial fibrillation by increasing Coreg if needed to 12.5 milligrams twice a day. And if the AFib is not controlled at this point, Coreg can be further increased. Again, we always want to ensure patient safety. We want to make sure that Penny has a repeat EKG to monitor for any arrhythmias or EKG abnormalities, and also monitoring Penny's glucose levels. Next slide.
So within 24 hours of appointment, the primary care provider is advising Penny about the new medication orders and also providing instructions for discontinuing the atenolol and adding Coreg to her regimen. Penny will continue on the Zoloft at the current dose, and she does have a scheduled appointment with her primary care provider in 2 weeks. At the 2-week follow-up appointment, Penny does note that she's feeling much better and she's having more energy overall and cheerfulness. It's also noted that her blood glucose levels had greatly improved. So the treatment plan does appear to be successful. Next slide. So what we're illustrating here with this approach to e-consultation is really looking at how we can utilize e-consultation to address comorbid and complex needs. In this case, we had a primary care provider who was able to perform multiple e-consults with various specialists to really weigh in on the appropriate care for a patient. When we think about this, this is really what we do when we have a patient in the hospital. Patients come in, they're admitted to a room, and often we will then put out orders for specialists to go in and weigh in on the patient's care. We're basically creating a hospital without walls. We do this in a way to avoid costly duplication of care and testing. Think about it, one of the treatment recommendations here was to monitor blood glucose. Penny's on a continuous glucose monitoring device. So as long as that can be uploaded into the EHR, this is something that we can utilize to prevent having to have additional lab work and testing. We certainly decrease care fragmentation as the care is being really quarterbacked by the primary care provider, who does remain at the center of care. We also optimize care continuation by assuring all necessary information is sent to the specialist from the specialist back to the primary care provider, who is then weighing in and helping to orchestrate the care in the best possible manner. It prevents things like polypharmacy, network leakage, all of the things that can happen when patients go outside to receive their specialty care referrals. It also lowers the risk of expensive care, and you're preventing the ER use and also the use of out-of-network specialists, which can come with higher copays and deductibles for the patient. One of the things that e-consultation does in general, as many of you are aware on the call, is really reducing those direct costs. Multiple bills that can occur when you are seeing multiple providers who are doing multiple tests in various locations. Again, unnecessary duplication of lab work or monitoring and testing. There's indirect expenses that we see all our patients struggle with, everything from childcare costs, if you have to seek someone to watch your children, you have young children, maybe time out of work, travel expenses as the cost of fuel goes up. All of these things are avoided when you're doing e-consultation. We improve patient care. They have rapid access to a specialist. You're getting care back within hours of e-consultation. You are not having a delay in care. You're actually able to get ahead of any concerns the patient may have from a health perspective before they exacerbate and become things that now need to be addressed in a higher acuity setting. There's follow-up coordination that can occur with the primary care provider, again, being central to care. And you also limit patient challenges, anxieties related to travel. If we have elderly patients who may have difficulty leaving their home, this can address care needs that they have. Exposing folks to unfamiliar surroundings, lack of family support, or language barriers. As we mentioned earlier, if you have a patient who is seeking treatment from their primary care provider who speaks their native language, we're supporting all of these really important care delivery modalities. Next slide. So the benefit of e-consultation is we're always improving outcomes by utilizing the specialist advice and deploying that in our care guidance, increasing health equity, making care easier for the patient to receive, whether it's long wait times, travel problems, issues with accessibility because there's limited number of specialists in a given area. E-consultation can address all of this. You can manage comorbidities. In this case, this is illustrative, but we are seeing this being utilized more and more post-pandemic with primary care providers deploying this multi-pronged approach to e-consultation. And then again, decreasing that time to treatment, getting ahead of concerns while they're still resonating with patients, getting them to be able to become more compliant with treatment plans because you're treating in real time. And again, when that concern is top of mind for the patient. If you consider deploying e-consultation in one of your practice settings, things to keep in mind is certainly to really involve your entire care team. You know, make a plan with your patient, tell them what is going to occur. Tell them about the e-consultation process and what they can expect. I should be getting back to you within so many hours, and I will let you know if this is something that we can treat at the primary care level, or if it's something where you will need to see a specialist. In many instances, if you've done an e-consult and the patient does need to see a specialist, the specialist may provide interim care advice that will help to keep the patient stable while they're waiting for that care. For your practice, emphasize that you're in this together. We're all working to the betterment of the patient. And then again, setting clear expectations for the patient that there could be 3 possible outcomes. You won't need a specialist appointment. We can treat you at the primary care level. There may be further testing needed, or you may need to go forward, but we have an interim care plan that we can put you on while you're waiting to be seen. And again, make a plan with the patient to close the loop. I'd like you to come back for additional testing. I'd like you to come back for a repeat EKG. I'd like you to come back in a couple of weeks to assess the medication changes that we've made. In this case, it worked out well for Penny. In many of the cases that we see very positive results taking this kind of a team effort approach. So to recap everything that we were discussing, again, e-consultation is a powerful tool, and it can be utilized to address complex comorbid care through the use of multiple e-consults for multiple conditions and comorbidities. As I mentioned earlier, you can replicate in many ways a hospital without walls concept by tapping into multiple specialists and weighing in on the best treatment options for your patient. More importantly, we are empowering primary care providers as quarterbacks to be the care delivery agents for their patients and remaining central to the patient's care. We're preventing things like polypharmacy, multiple visits, multiple costs, duplication of testing. We keep the care within the purview of the patient's trusted PCP. This improves outcomes and certainly health equity. And then we optimize care coordination for patients. So it prevents, again, all of the duplication that I've mentioned, and it also helps to prevent that myopic version of care delivery. It becomes more holistic. Libby?
Thanks so much, Pam. These are really great and patient-focused comments on the process of e-consult, and I really love the fact that you tied it back to, what does the patient really get out of this, and what does the team, the primary and specialty care team, need to do to close this out with the patient and make sure that they're engaged in the process. I have a sort of a non-clinical question for you, since I'm not a clinician. And as I'm asking this question, I encourage those who are on the call to use the chat to share your questions. We'll open it up in just a moment here. But Pam and Dr. Cladera, from just the outside observer perspective, you have a patient here who's got a lot going on. And since e-consult is meant for sort of routine or non-urgent questions, a lot of these that you have addressed through specialist recommendations around medication or tests, those are not emergent needs. Those weren't reasons that a patient should have to go to the ER. How do you or Dr. Cladera give advice as to, if you're managing this patient's needs over time, what would alert you to the fact that it's no longer an e-consult? This has gotten to the point where you really do need to see that patient in person, because there were so many recommendations within that was so helpful to keep that relationship with primary care, but at a certain point, it may sort of go beyond what can be dealt with by the asynchronous communication. Do you have any advice there?
Absolutely, and that's a very, very pertinent and excellent question, Libby. Ultimately, patient safety is our number one concern. And so we encourage specialists who partner with us that this is a great opportunity to educate primary care providers in sharing clinical pearls. When making recommendations that include medications, it's always helpful to include side effects or harmful interactions that the patient may be on or that the specialist is recommending. When there's conditions, for this particular example, like Penny, who has components of depression, a patient who states suicidal ideation or intent to harm, that is a red flag. That is no longer an e-consult. That patient, if expresses one or the other, needs to be forwarded. I always appreciate also when a specialist is able to provide pitfalls, pertinent side effects, so that primary care provider can share it with the patient, so that if those events or symptoms were to manifest, that primary care provider and that patient can seek a higher level of care, such as an emergency department or urgent care.
Thanks, Dr. Cladera. And this is so important, I'm sure, to all of you who see patients, those of you who are responsible for mental health, especially coming out of the pandemic, the fact that we're about to get to May, which is Mental Health Awareness Month. That's why I wanted to ask that question, Dr. Cladera. When do these questions escalate to the point of needing additional hand-holding and in-person, perhaps in-person help? So thank you for clarifying there. Just want to check to see if we have any questions from the audience. Please do use the chat if you have any questions and you're not in a place where you can unmute. I will do a quick pause if anyone would like to unmute themselves and ask a question. Okay, well, I'm waiting for that. If you, I did my pause, so back to the chat. If you have a question, I have one more question for Pam and Dr. Cladera. it's so clear that there is a great advantage to patients, reducing travel, reducing the need to schedule visits and deal with long wait times for specialty care that we're facing across the country. What advice do you give to primary care providers? This looks like a bit of back and forth, which of course we know is the case with eConsult, that it's a great opportunity to communicate and learn between primary care providers and specialists. What do you recommend to primary care providers in terms of fitting this in their schedules? How do you suggest that they do this within their busy work days? Do you have any thoughts there?
Pam, did you want to take this question?
Sure, absolutely. So I think it's going to depend on each individual practitioner. They know what their bandwidth is and they know what their care capabilities are. What are they comfortable doing? One of the things I think is important with deploying any e-consultation program is really to get a good sense of what is the workflow in a particular practice setting, what are the treatment capabilities, and then communicating that back to your specialist team so that they can be sure when they are making recommendations, they will fit within the care purview of that particular center. Also, there are other things that you can do from a client's support perspective, as well as additional training and resources that you can provide that will help with the clinic. And that will vary according to, whoever is providing the service.
Thanks, Pam. I appreciate that. And it's obviously this is evolving, and as we hear from primary care providers what their needs are, we try to provide tools like this, opportunities to have a conversation around how how best practices can be employed into provider workflows. So I think we're probably near the end of our Q&A. If there's anything else from the group, please do submit it by chat. But perhaps Dr. Cladera and Pam, you have any final comments, just food for thought as we think about patients' needs coming out of the pandemic, patients with multiple comorbidities? Any thoughts of how to approach these cases?
Yeah, I would just say, keeping in mind that, I think e-consultation is such a valuable tool. And I suspect in many instances, it often isn't the first thing that we think about. It may be something we think about as the last thing. So really getting creative and looking at your patient populations, the demographics, and understanding how do we keep the primary care providers. It's one thing to say it, it's another thing to actively, do this, which is keeping the primary care provider central to that care. And that primary care provider may be a physician, it may be a nurse practitioner, it may be, a physician's assistant. E-consultation, as you mentioned, Libby, it's such a powerful tool, and that we can manage patients in a very safe way. And at the same time, it does provide learning for mid-level practitioners and folks to be able to work at the top of their license or increase their scope of care. So I think these added benefits are something that as we start to deal with more challenges, whether it's more mid-levels practicing medicine, filling in for physicians, or busy practices where patients can't get in to see specialists, this becomes a really viable tool for addressing those needs.
Thanks so much, Pam. Dr. Cladera, any final thoughts?
Absolutely. I think it's always good for the primary care provider to remember our sample cases had 3 specialists that said that primary care options were available. But sometimes there's not going to be a primary care option available. In those particular cases, we encourage the specialists to still make interim care guideline recommendations. Are there labs that can be obtained in the interim? Are there diagnostic studies that could be obtained in the interim? Are there any suggestions that can be performed or offered to the primary care provider so that time is not wasted, so that that primary care provider can have options for that patient while they wait for that in-person consultation with the specialist?
Great, super helpful advice, and appreciate your really thoughtful response to what we've faced through over the past couple of years: long wait times, patients who have avoided care, perhaps delayed care through the pandemic, and through isolation, through the impact on patients' mental and behavioral health. We've seen so many different and increased needs for this kind of care. So thanks so much for your thoughtful presentation today.